Before I start, to simplify it, it's kind of like when I think of the word anesthesia, I think of general anesthesia, local anesthesia, and afternoon lectures. I realize that this session is having actually the opposite effect, and everybody's excited about it. And actually, to borrow the line from Lee, we're kind of having some PTSD looking at some of the slides that. So in the talk today, I'm going to borrow the line from Wei about our patient Tom, who underwent the whole evaluation for with the failing Fontan, and then ended up getting the transplant late last year. But I'm going to focus on the last part of the slide there in 2018 while he was hospitalized. So everything, basically, the patient has been worked up for transplant. Everything is kind of lined up. Now he's hospitalized, and are we now basically high-fiving each other and kind of waiting for the heart, or is there more work to be done? And certainly the answer is a lot of work still needs to be done. One thing I will not mention in this talk is the desensitization process while the patient is hospitalized, because as Dr. Cruz beautifully already explained in detail. But I will talk about a few topics that are that are on the slide. The venous access and anticoagulation while the patient is hospitalized, hemodynamic optimization, and these first ones go together, collateral vessel evaluation and coiling, arrhythmia burden assessment, and some of the more patient-specific topics such as emotional support, nutrition, ambulation, bleeding, and infectious disease. Most of the non-congenital patients who are waiting in the hospital for heart transplant have some kind of central access, Swan-Ganz catheter, to continuously monitor their hemodynamics. However, for most complex congenital patients, that's not realistic, and especially for the Fontan patient, that's probably detrimental, if anything. So in such cases, for Fontan patients, and in this case for Tom as well, the Swan-Ganz catheter was avoided. And again, for different reasons, anatomic consideration, but also because of the low non-pulsatile flow, having a catheter in the pulmonary artery is definitely, it's a risk for clot, and as well as arrhythmia burden. So a PICC placement is usually elected in these cases, and that is used for vasopressor initiation, heparin drip, and so forth, and routine blood draws. Bear in mind that these patients will be in the hospital for weeks, if not months, with daily blood draws and so forth, so having some kind of access and preventing daily poking with needles, it's definitely not a minor feat. So the patient was admitted. The timeline there is for 2018, admitted on October 21st, and PICC line was placed the following day, and milrinone was started immediately, and then 2 days later, dopamine. As you recall, he already had some kidney injury, a chronic kidney disease that had worsened prior to him being admitted. And this is the creatinine that was around 3 when he was admitted. He was starting on milrinone and dopamine, as I said. And shortly thereafter, we see an improvement in his creatinine, in his kidney function, which is a good thing. It kind of gives us some optimism to see that there is reserve in his kidneys as well. Though obviously, there is a high risk for these patients to end up in dialysis, but the fact that we see already an improvement, it is really something that we really like to see. One practical advice, at least in our center, we've seen that, and this could be possibly hospital-specific and the assays that are used, but what we noted is that if we check the blood draws and the blood is drawn from the same port where the dopamine is infusing, at least in our center, it gives us falsely low creatinine levels. And we kind of have seen this several times now, and so the point is that every time you see something that is kind of doesn't add up and it's really doesn't make sense, and we had a lot of numbers like creatinine is 2, but the next day is 0.7, and then 2 again. It's like, where is this coming from? In this particular case, we discovered it was because it was being collected from the PICC line where the dopamine was running. So he had the PICC line placement, as I said, starting on milrinone and dopamine, and the next thing is, the next point that we start looking into is the reassessment of the collateral vessels. And this is something, as Dr. Abulhassan mentioned, we've been much more aggressive and more recently because these patients have a lot of collaterals. They are arterial collaterals, they are veno-veno collaterals. And in our experiences, these arterial collaterals that probably pose the major risk of bleeding, obviously the veno-veno collaterals as well. And knowing how the collateral burden and being able to get rid of whatever collateral we can, it's really something that I think will help the patient when the patient is in the operating room in terms of reducing the bleeding risk. So patient on the 26th, so 5 days after he was admitted, he had a CT of the chest to reassess the collateral burden to see, usually it's in ECG gated, to see where the vessels are they arterial pulmonary, veno-veno collaterals. And the following day, he was taken to the cath lab by Dr. Abulhossein. And this is just a representation of, he had 5 collaterals coiled at the time. Interestingly enough, this one is from the descending aorta, going right in the lung fields there, as you see in the clip, and it goes in the subclavian artery. That's right in the surgical field area. So there were 5 vessels that were coiled. And here we have to be careful, and it's very patient-specific. There is already some kidney insufficiency, so we have to be very mindful of the contrast, the amount of the contrast we're using. We have to be mindful of, obviously, of the radiation. These are long procedures, and sometimes it might take more than one trip to the cath lab to get a successful result. And sometimes just in this particular case for Tom, it was only one trip to the cath lab. And a lot of times, with the help of Dr. Prosper, who talked earlier about the MRI, we are able also to recalculate the QPQS via MRI if it makes a difference, if the QPQS changed or not. So going back to with regard to the coiling, he had the arterial collateral coiling on the 31st, and then now on a daily basis we assess his arrhythmia burden. These patients are already at risk for arrhythmias, and now we put them on dopamine, milrinone, and the last thing we want, but sometimes see this, we do see an increase in arrhythmia burden in some patients. So kind of we have to have almost like a backup plan. How if we see an increase in arrhythmia burden that can really cause a decompensation of the patient, that we have to, like, well, what is our next step? Do we modify the vasopressors? Do we introduce antiarrhythmic agents, beta blockers? Sometimes dopamine and metoprolol, carvedilol, which I know it doesn't make sense, but trying to have the patient as stable as possible while he or she is waiting for the heart, and discussion of the mechanical support that Dr. Reardon talked about. And thankfully for Tom, there was not a huge increase in the arrhythmia burden. He's, PVCs here and there, but nothing that we really had to modify significantly during his hospitalization while he was waiting for the transplant. And I think lastly, but most as importantly, it's a few specific things. Emotional support. These patients will be for weeks and months, and they will see so many faces, house staff, physicians, in and out. We switch every week or so. So it's nice to have a few familiar faces that the patient is familiar with, that the patient has seen really for years before that really they can rely on those. Otherwise, it is stressful for the patient and the family. They are going through an experience that nobody else can understand unless somebody has gone through the transplant process. Nutrition. Nobody really likes the hospital food. I mean, I know I don't. But kind of being mindful of that. Again, they are there for weeks and months. And ambulation, being able not to lose the ability to be as active as they can possibly be. We strongly encourage these patients several times a day to go in the halls and walk and be as active as possible. Bleeding is a real risk. We do have these patients on heparin, as I said, simply because they have a central catheter. They're at risk of clots. And there was a few times that there were minor episodes of bleeding for Tom, but nothing significant to deter his transplant. And infectious disease is the other topic. They have central line catheter. They go through the desensitization process. There are times that they have to go to status 7, basically off the list, until the infection process is taken care of, and then back on the list. Those are the main things that I think apply to this particular case. And one minor thing, They are with us for weeks and months, and we draw blood on them every day, several times a day, and we're wondering, why are they anemic? Are they bleeding? It could be just because we're giving them the anemia of chronic investigation. Thank you.